Welcome to this session presented by Ms. Prudence Hamito. So as we all know, there are complications that usually arise, especially when a newborn or when a baby is just born. So when we look at complications, there are those problems that develops from an existing illness or even any situation that is difficult to identify. So we shall be looking at these complications of newborn, or those things that always arise, especially when a baby is just born. So our first for today is hypothermia. Hypothermia is defined as a body temperature of less than 35 degrees Celsius. So in most cases, when we talk of hypothermia, is when we are looking at the temperature. So thermoregulation, this takes us back to thermoregulatory adaptation. So thermoregulation is that balance between heat loss and heat production to maintain a normal body temperature. So thermoneutral environment is that environment which has minimal oxygen use and energy for temperature maintenance. So we are looking at hypothermia today, which is one of the complications that most times arise in newborn. So as we looked at thermoregulation, we saw that there are a lot of adaptations that the fetus needs to undergo to make sure they do not lose heat, because it is when they lose heat, that's when they come up with this complication of hypothermia. So hypothermia is, according to WHO, is defined as having a temperature taken from axillary of less than 35 degrees Celsius in newborns or less than 28 days. So the normal temperature of a newborn is 36.5 degrees Celsius to 37.5 degrees Celsius. So there are also classifications of temperature. We have the normal one, then we have the mild one being 36.0 to 36.4 degrees Celsius. Then we have the moderate one, which is 32.0 to 35.9 degrees Celsius. Then the severe one, the one we are calling hypothermia, is that which is 32 degrees Celsius. So this is according to WHO. So why are newborns prone to heat loss? So the newborn are prone to heat loss because they have a much thin skin. I don't know if you have ever cannulated a newborn, but you find that their skin is actually very thin. So they have a thin skin that makes them prone to heat loss. And they have blood vessels which are close to the surface. So their blood vessels are just underneath the skin, and this makes heat loss to be easy. Then we have limited subcutaneous fats, especially those born prematurely, even those other ones which are born maturely, so long as the baby has some kind of limited subcutaneous fats. Then we have large surface area relative to body mass. So all these can make the baby to easily lose heat. Then we have risk factors for hypothermia. So one of the risk factors for hypothermia is prematurity. So all those babies who are going to be born less than 36 completed weeks of gestation are those ones we call premature babies. So they are prone to having hypothermia because they have limited brown fats, they have a much thinner skin, they have all those other things. So this makes babies born prematurely to have a higher risk of developing hypothermia. Then we have those born with low birth weights. So it does not mean that only babies born prematurely have low birth weight. Even the ones born at term, they can easily have low birth weight. So those babies who are born of less than or born from 2 kilograms below, those ones are the one we are calling low birth weight, and they can easily have this complication of hypothermia. Then we have fetuses, which are, or newborns, which have in uterine growth restrictions. So there are those babies who are born with growth restriction. You find that they have they are small for gestation. So these babies have higher chance of getting hypothermia. Then we have asphyxia, and then other congenital anomalies or abnormalities. So this is one of the risk factors, or one of the neonatal risk factors that can easily make the fetus or newborn to have hypothermia. Then we have environmental risk factors. One being a cold delivery room. So if we are having a delivery room which is extremely cold, yes, the delivery room should be well ventilated, but not very cold. So a cold delivery room can easily make the newborn to lose heat and then goes into hypothermia. We have delayed drying. Most times, if you delay to dry the baby after birth, or you have not dried the baby thoroughly, drying thoroughly means you dry every corner, making sure that there is no moisture or amniotic fluid which is remaining on the baby to prevent this hypothermia. So delayed drying or drying that is partial can easily make the baby to have hypothermia. We have bathing. So the babies are supposed to be bathed at least 24 hours following birth. So in most times we tend to bathe these babies immediately when they come out from the uterus, which is not correct. That can easily predispose them to hypothermia. Remember, they're still undergoing adaptations to temperature regulation. So we have vernix removal. So the vernix is that whitish thing we see on the baby's skin, on the head. And most times, the reason as to why we predispose the babies to hypothermia is we want to remove away the vernix. And yet this vernix is the one that can help this baby to regulate heat and also to make the skin to shine, even if you don't smear the baby. Then we have maternal risk. One of the maternal risks is the mother also having low temperature. So if the mother has been having low temperature while laboring, you should know that this baby is going to be at risk of hypothermia while after birth. Then we have poor breastfeeding initiations. So some people would want to breastfeed the baby, and yet they are breastfeeding while the baby is exposed. So if you do not know how to breastfeed your baby, you will tend to expose the baby to coldness and then breastfeed. So that can easily put the baby at risk of hypothermia. Then we have some other systemic risk. For example, poor provider's knowledge. So this provider's knowledge is you the health worker. So if the health worker does not really know how to manage how to make sure that the baby does not go into hypothermia, it can easily make them to lose heat and then they go into hypothermia. Then we have inadequate neonatal transport. So sometimes one of the reasons, maybe the baby was born with fetal distress, and then you want to transport this baby to neonatal unit. You do not have a proper mean of transport to transport this newborn to neonatal unit. So as you're transporting from the delivery room to the neonatal unit, this baby can easily be at risk of losing heat, which would put them into hypothermia. Then we have surgeries. Surgeries and imaging, especially for those babies born with those born with congenital anomalies. So those babies born with congenital anomalies get exposed because some of those anomalies might be, or abnormalities might require immediate surgery that exposes them. Others might require imaging that exposes them. And all this will make the baby to lose heat and probably go into hypothermia. So the prevalence of hypothermia varies globally. So we find that around 8 to 92% is based on regional and quality care. So this percentage is still quite high. So in developing countries like South Sudan here, we have about 32 to 85% in hospitals, even in tropical settings. So we find that we still have a lot of newborns undergoing or suffering from hypothermia. So other outcomes of hypothermia include independent risk factors for mortality in all gestational age. There is 28% increase in mortality per 1 degree drop below the normal. Then there is that link of IVH, the one for BDP. There is also sepsis. There is this right occipital posterior position, others or longer hospital stay, and all those things. So all this can easily predispose the newborn to hypothermia. So we have temperature measurements. So we have some sites where we can take temperature from and what we can use for taking temperature. I think this is not something new. So the preferred site for newborn is the axilla. So in the axilla, we can use the digital thermometer about 15 seconds or until when it beeps. So we have the other digital one that can ring after some minutes. Then we have continuous monitoring using thermistor or on radiant warmer or incubator. So there are these incubators or the one for continuous monitoring, which can give you the temperature at which the baby is in, especially those in neonatal units. Then we have rector. That is one side, but it's not preferred except if you have infrared thermometers. Then we have imaging techs, for example, hypothermia detecting bracelets. So there are those bracelets which have been formed. So you just put in the baby's arm and it is able to detect the temperature. So we have other mechanisms of heat production. So as you see, if the baby is going into hypothermia, or if you see that the baby's temperature is beginning to drop, you can have other mechanisms to allow the baby to not lose it, or other mechanisms the baby can adopt to prevent it from losing heat. So one of which we already mentioned, which is non-shivering thermogenesis, where we are having metabolism of brown fats via the beta-adrenergic stimulation. Then we have increased metabolism by the brain, liver, and the heart, which generates heat. Then we have peripheral vasoconstrictions, reduces heat loss from the skin. Then we have mechanisms of heat loss, which we already mentioned. One by evaporation, amniotic fluid drying off. Then we have conduction, contact with cold objects like the trays, the clothes. Then convection, cold air currents, open windows, fans, radiation, lost to cooler nearby surface like walls and equipments. So we have clinical features, one of which is peripheral vasoconstrictions. So these are signs and symptoms which can easily help you to tell if the baby is going through hypothermia. So one of which is cold limbs. So when the baby is beginning to have extremely cold limbs, you can easily tell that this child is undergoing hypothermia. Then acrocyanosis. We also have CNS depression. So you find that these children who will begin to undergo hypothermia, it will affect the CNS and it becomes depressed. Then when that happens, we have the child begins to become lethargic. Then there is bradycardia, there is apnea, it begins to have poor feeding and all those things. Then we have metabolic stress. So one of the clinical features of hypothermia is hypoglycemia. So as the baby loses heat, it also loses glucose. So this makes the baby to go into hypoglycemic state, and then it can also make the baby to go into hypoxic state, and finally acidosis. So those are other metabolic stress that will come because of hypothermia. Then others like DIC, disseminated intravascular coagulation. We have poor weight gain, those newborns who are born with less weight. We have respiratory distress, those that were having respiratory distress, either asphyxia or maybe fetal distress. So all these ones would be indicating for hypothermia. Then a prevention of hypothermia while in delivery room. One, we follow the 10 WO steps for warm change. So the delivery room should have temperature of 25 to 28 degrees Celsius. Then we have pre-warm lineage and warmers, and then caps. So these are the bed sheets you're going to use for covering the baby. Then we have skin-to-skin contact after delivery, because the mother's skin is is warmer than that of the baby at birth. So it's good that you allow thermoregulation to take place. As the baby is losing heat, it can gain from the mother through skin-to-skin contact. Then begin early breastfeeding and delay bathing. Use heated gases, warm fluids during resuscitation or surgeries. So if you have any kind of procedures that you're doing on these newborns, you should make sure you're using warm fluids. You're using even IV fluids. If you're giving, it should be something warm. Then we have, for babies which are less than 32 weeks, use plastic wraps, and we can use transformer mattresses. So there are those mattresses found in neonatal units which you can use to keep the baby warm. So prevention in neonatal units, we have in NICU, neonatal ICU, and postnatal wards. So we have the use of servo-controlled warmers. We have those clean wraps, and then giving warm IV fluids. So we shall be giving warm IV fluids while in NICU. We can use creams or oils less than 72 hours to reduce water loss. We can also use discharge criteria of abdomen, warm abdomen, and feet. Then when in postnatal, we can use still skin-to-skin contacts. Beyond first hour is very essential, especially for the first 6 hours. So if the baby is having hypothermia, it's best you put the baby on skin-to-skin contact with the mother. Then sharing beddings with the mother helps to maintain warmth. So there is this, you can still put the baby's blankets and all those things, but still you cover your baby with the blankets you yourself are using. Then prevention while transporting, we have for stable infants or for stable newborns, we can wrap them, then we put a cap on their head. So as you're transporting your baby back home, make sure the baby is covered with at least 3 warm bed sheets, and then you put a cap on the head. Then for sick infants, we use transport incubators if available. So if you have some kind of incubator that you can assist the parents to take their babies at home, yeah, you can give them if it is available. Alternatively, we can use plastic bags plus skin-to-skin contact plus the cap, or we can do the most practiced one, which is kangaroo care. Then we have phase change material. So you need to keep changing materials. So the baby has urinated, you change, you don't allow them to sleep on it for long. That is how they can also lose heat. Then rewarming protocols. We have mild temperature, which is 36 to 36.4 degrees Celsius. So here we do rewarming by putting the baby on skin-to-skin contact plus a blanket. So this can easily increase temperature by either 0.5 degrees Celsius or every 30 minutes. So you make sure that when you put the baby on skin-to-skin plus a blanket, you check to see if there's increase in the temperature. Then we have the ones who have moderate temperature, that is 32 to 35.9. We put them on incubator. So we use incubator or we use radiant warmers. Then the ones who are having less than 32 degrees Celsius, those are really hypothermics. So we put incubator warming and we set it at 35 to 36 degrees Celsius. We do slow rewarming after 35 degrees Celsius. Then we provide them with oxygen, fluids, monitor vital signs, and glucose. Remember, we said hypothermia can easily lead to hypoglycemia and hypoxia. So monitoring and special considerations during this hypothermic stage. So we have measure toe core temperature gap, that is greater than 2 to 3 degrees Celsius. It suggests stress, infection, or shock. So if you get the temperature gap from the normal one is 2 to 3 degrees Celsius, you can suggest that the fetus is stressed, is having infection, or is going into shock. Then remove clothing during rewarming under radiant warmers. These radiant warmers are electrified. So when you're doing that, you need to remove the baby's clothes. Then we have check auxiliary temperature every 30 minutes post interventions. So for every intervention you're doing, you make sure at least every 30 minutes you check the auxiliary temperature. Then as you're trying to rewarm the baby, you make sure you investigate infections if there's no response in temperature after trying all the rewarming sessions or process. So we have what we call weak or preterm deliveries. So in most cases, these prematures or those born by cesarean section, we put them under radiant warmers. Do not dry. Place in plastic wraps up to the neck. Cover head with the cap. Transport in preheated incubator if possible. Transfer promptly to NICU. So these other babies who are born prematurely, this is how we handle them to avoid hypothermia. Then putting in skin-to-skin contact, that is what we call kangaroo method. So this is a technique whereby the baby is held upright, bare skin to the mother's chest. So the benefits of this kangaroo mother care is temperature is maintained. It improves bonding also between the mother and the baby. It stabilizes heart rates. It will help to reduce crying of the baby, and then early hospital discharge. So even if the baby was having hypothermia, this mother will not have to stay in the hospital for a long time. So thank you so much for listening. That is where we are going to end with our session today for hypothermia. So all what you need to put in your mind is to prevent this hypothermia from occurring in the first place. So that means our monitoring begins right from during labor. So you should know that when the fetus is having fetal distress, or if the mother is having a low temperature, the fetus is most likely going to be born and will suffer from hypothermia. So we usually, from what we have advised, make sure that you clean or you dry the baby thoroughly and put on skin to skin contact to avoid that baby from losing heat. So if there are fans around the delivery room, you make sure you turn them aside to prevent the baby from losing heat. So thank you for paying attention. We shall end our session here. See you next time.